Hi, this is Professor Capron. Welcome to this presentation on ECG waveforms. Let's take a look at the learning objectives for this presentation. By the end of this presentation, you'll understand the significance of each ECG waveform and interval, be able to identify the normal values and duration of key ECG waveforms, be able to interpret the correlation between ECG waveforms and phases of the cardiac cycle, and recognize abnormalities in ECG waveforms and their possible clinical implications. Here we have some key terms that I really need you to understand. Read through them, make a note, and come back at the end of the presentation and make sure that you have a good grasp of each of these key terms. Let's look at an overview of the ECG waveforms and their importance in clinical practice. First, let's understand what ECG waveforms are. ECG, or electrocardiogram, is a test that records the electrical activity of the heart over a period of time using electrodes placed on the skin. The resulting graph shows different waveforms that correspond to specific phases of the cardiac cycle. Each waveform on an ECG represents a different electrical event in the heart, and these events are crucial for the heart's ability to pump blood effectively. The P wave represents atrial depolarization. This is the electrical activation of the atria. When the atria are electrically activated, they contract and push blood into the ventricles. The QRS complex represents ventricular depolarization. During this phase, the ventricles are electrically activated and they contract to pump blood out to the lungs and to the rest of the body. The QRS complex is crucial because it reflects the main pumping action of the heart. The T wave represents ventricular repolarization, which is the process of the ventricles returning to their resting state after contraction. It's important for the heart muscle to repolarize properly so that it can be ready for the next heartbeat. The PR interval is the time from the onset of the P wave to the start of the QRS complex. It reflects the time taken for the electrical impulse to travel from the atria to the ventricles. A normal PR interval indicates that the electrical conduction pathway is functioning properly. And the QRS duration is the time taken for the depolarization and repolarization of the ventricles. A normal QRS duration indicates that the ventricles are being activated in a coordinated manner, which is essential for effective pumping. ECG waveforms are not just lines and peaks on a graph. They provide vital information about the heart's electricity and its ability to function properly. By analyzing these waveforms, healthcare providers can diagnose various heart conditions such as arrhythmias, myocardial infarction, that's a heart attack, and electrolyte imbalances. For example, a prolonged PR interval can indicate a first-degree heart block where the electrical signals are delayed as they move through the atria to the ventricles. A widened QRS complex can suggest a bundle branch block where there's a delay or blockage along the pathway that electrical impulses travel to make the heart beat. Abnormalities in the T wave can indicate issues such as ischemia, reduced blood flow to the heart muscle, or electrolyte imbalances like hyperkalemia, which is high potassium levels. These conditions can be life-threatening and require prompt medical attention. So understanding and accurately interpreting ECG waveforms are essential skills in diagnosing and managing these cardiac conditions. This ability helps to aid in timely intervention and appropriate treatment, which improves patient outcome. Now let's look at the P wave in more detail. Understanding the P wave is crucial not only for interpreting ECGs, but for identifying potential atrial abnormalities. The P wave represents atrial depolarization. Depolarization is the process by which the heart's electrical cells become activated, leading to muscle contraction. Specifically, the P wave reflects the electrical activity that starts in the sinoatrial or SA node, spreads through the atria, and causes them to contract. This contraction pushes blood from the atria into the ventricles. A normal P wave duration is less than 0.12 seconds, which is less than 3 small boxes on the ECG graph paper. It's important to measure the P wave accurately because its duration can provide clues about the electrical health of the atria. Remember that the P wave indicates the electrical activity in the atria, so a normal P wave suggests that the atria are depolarizing correctly, so the SA node is functioning well, and the atria are contracting in a synchronized, coordinated manner. but abnormalities in the P wave can indicate several conditions. If the P wave is abnormally tall and peaked or broad and notched, it can indicate atrial enlargement. Left atrial enlargement often shows a broad, notched P wave, while right atrial enlargement shows a tall, peaked P wave. Atrial enlargement can result from conditions such as hypertension, valve disorders, or chronic lung disease, which increase the workload of the atria over time. Variations in the P wave can suggest arrhythmias originating in the atria. For example, atrial flutter may show multiple P waves between QRS complexes, often with a characteristic sawtooth pattern. But atrial fibrillation typically results in the absence of distinct P waves. They're replaced by rapid, irregular fibrillatory waves. An early P wave followed by a normal QRS complex may indicate premature atrial contractions. These are extra heartbeats originating in the atria. They're very common. They're often benign, but they can lead to more serious arrhythmias if they are frequent. If the P wave has an unusual shape or it's inverted, it may indicate that the electrical impulse is originating from an ectopic focus within the atria rather than from the SA node. This can occur in conditions such as atrial tachycardia. In clinical practice, careful examination of the P wave can help in the early detection and management of these conditions. It's essential to not only look at the presence of the P wave, but also its shape, its duration, and its relationship to the QRS complex. For example, in conditions like first-degree AV block, you might see a normal P wave followed by a prolonged PR interval. In more severe AV blocks, a P wave might appear normal, but the QRS complexes become dissociated from the P waves, indicating a disruption in the transmission of the electrical impulse from the atria to the ventricles. Now let's look at the QRS complex. Understanding the QRS complex is essential for assessing ventricular function and diagnosing various cardiac conditions. The QRS complex represents ventricular depolarization. Remember, depolarization is the process by which the ventricle's electrical cells become activated, leading to ventricular contraction. This is the most critical part of the heart's pumping action, as the ventricles are responsible for pumping blood to the lungs and to the rest of the body. The QRS complex typically consists of three deflections. The Q, which is the initial negative deflection following the P wave. The R, which was the first positive deflection, and the S wave, which is the first negative deflection following the R wave. A normal QRS complex duration is between 0.06 and 0.12 seconds. This corresponds to 1.5 to 3 small boxes on the ECG graph paper. The duration of the QRS complex is a vital measurement because it indicates how long it takes for the ventricles to depolarize. The QRS complex reflects the electrical activity in the ventricles. A normal QRS complex suggests that the electrical impulse is traveling through the ventricles in a coordinated manner, leading to effective ventricular contraction. However, abnormalities in the QRS complex can indicate several different conditions. We might have a bundle branch block. A left bundle branch block results in a prolonged QRS duration greater than 0.12 seconds because the electrical impulse is delayed as it travels through the left bundle branch. This causes the left ventricle to depolarize later than the right ventricle. A right bundle branch block is similar to a left bundle branch block, and it also results in a prolonged QRS duration. The delay occurs in the right bundle branch, causing the right ventricle to depolarize later than the left ventricle. Both conditions can be identified by characteristic changes in the QRS complex and are associated with underlying heart disease or structural abnormalities. Left ventricular hypertrophy is a condition characterized by an increased voltage in the QRS complex. The left ventricle has to work harder and becomes thicker, often due to hypertension or aortic stenosis. The increased muscle mass results in a stronger electrical signal reflected as taller QRS complexes. In right ventricular hypertrophy, we also see an increased voltage of the QRS complex. This is typically due to conditions such as pulmonary hypertension or congenital heart disease. Then we have the ventricular arrhythmias. Let's start by looking at premature ventricular contractions. These are early, wide, bizarre-looking QRS complexes that occur independently of the normal atrial contraction. They indicate an ectopic focus in the ventricles that triggers depolarization before the normal impulse arrives from the atria. In ventricular tachycardia, we see 3 or more consecutive PVCs with a wide QRS complex. Ventricular tachycardia can be life-threatening and requires immediate medical intervention. And then ventricular fibrillation is when we see a chaotic, irregular rhythm with no identifiable QRS complexes. This indicates that the ventricles are just sitting there quivering. They're not effectively pumping blood. Ventricular fibrillation is a medical emergency and requires immediate medical intervention. Myocardial infarction or a heart attack, this is shown when the Q wave is abnormally deep or wide. This can indicate a previous myocardial infarction. The Q wave represents the necrotic tissue in the heart where the impulse does not travel normally. In clinical practice, examining the QRS complex is vital for diagnosing and managing these conditions. It helps to assess the efficiency of ventricular contraction and identify any delays or abnormalities in the electrical conduction system. Now let's focus on the T wave. The T wave represents ventricle repolarization. Remember that repolarization is the process by which the ventricles return to their resting state after depolarization. It's the movement of ions across the cell membrane that restores the negative charge inside the heart muscle cells after depolarization, and it prepares the ventricles for the next cycle of depolarization and contraction. It's essentially the recovery phase of the ventricles. The heart muscle cells reset their electrical states to be ready for the next heartbeat. This repolarization phase is vital for the heart's ability to maintain a regular and effective rhythm. So what do we want to see? The T wave is normally upright in most leads. It should be rounded and smooth, and the height of the T wave is generally less than 5 millimeters in limb leads and less than 10 millimeters in precordial leads. Let's talk about when it's abnormal. Inverted T waves can indicate ischemia. This is where there's a lack of blood flow and oxygen to the heart muscle. T wave inversion is often seen in leads corresponding to the affected area of the heart. Tall peak T waves can be a sign of hyperkalemia, which is a level of potassium in the blood. Hyperkalemia can have serious effects on the heart and requires immediate attention. Flattened T waves can be associated with hypokalemia or low potassium levels. Potassium is critical for proper cardiac function, and low levels can lead to dangerous arrhythmias. A T wave that goes up and then down is called biphasic, and this can suggest ischemia, and it may be seen in the setting of a myocardial infarction or heart attack. And then we have what's called T-wave alternance. This is a pattern where the T-wave changes in amplitude or shape with each heartbeat and can be a precursor to serious arrhythmias like ventricular tachycardia. Remember, abnormal T-waves are often one of the earliest signs of myocardial ischemia and infarction. Monitoring changes in the T-wave can help in early diagnosis and timely management of these conditions. And since the T wave is sensitive to electrolyte levels, particularly potassium, and calcium, it can provide early indications of electrolyte disturbances. Prompt correction of these imbalances is crucial to prevent arrhythmias. Finally, some medications, particularly those affecting cardiac function, can alter T-wave morphology. For instance, digitalis can cause T-wave changes known as digoxin effect, characterized by a scooped-out appearance of the ST segment and T-wave. Now let's take a look at the PR interval. This is the time from the onset of the P wave to the start of the QRS complex. This interval represents the period during which the electrical impulse travels from the atria through the AV node and into the ventricles. Remember, the P wave indicates atrial depolarization, and the QRS complex indicates ventricular depolarization. The normal duration of the PR interval is between 0.12 and 0.2 seconds. This corresponds to 3 to 5 small boxes on the ECG graph paper. A duration within this range indicates that the electrical impulse is traveling through the AV node and the rest of the conduction system at a normal speed. So again, a normal PR interval indicates the conduction system is functioning correctly with the timely transfer of the electrical impulse from the atria to the ventricles. Now, a prolonged PR interval, something greater than 0.2 seconds, is considered prolonged. This condition is known as first-degree heart block or first-degree AV block, and it indicates a delay in the electrical conduction through the AV node, which can be due to various factors such as medication effects, such as beta blockers, calcium channel blockers, increased vagal tone, or underlying heart disease. A prolonged PR interval is the hallmark of first-degree heart block. In this condition, every atrial impulse is conducted to the ventricles, but it takes longer than usual. First-degree heart block is often asymptomatic and found just incidentally on an ECG that we're doing for other reasons. However, it can indicate an underlying issue with the AV node that may need monitoring, especially if the patient is on medications that affect the conduction system or has conditions like ischemic heart disease. If the PR interval progressively lengthens until a beat is dropped, a P wave is not followed by a QRS complex, it is referred to as second-degree heart block type 1. This is also called Winkie-Bach or Mobitz 1. If some P waves are not conducted to the ventricles, but there isn't progressive lengthening of the PR interval, this is second-degree heart block type 2 or Mobitz 2, and this is more serious and may require a pacemaker. Now, a third-degree heart block is when there is absolutely no relationship between the P waves and the QRS complexes. The PR interval varies because the atrial and ventricular rhythms are completely independent of one another. There is a situation when a PR interval is short. When it's shorter than 0.12 seconds, this can indicate pre-excitation syndrome such as Wolff-Parkinson-White. In Wolff-Parkinson-White, an accessory pathway allows the electrical impulse to bypass the AV node, leading to a rapid ventricular response. The QRS duration is the time taken for the depolarization of the ventricles. Depolarization, again, is the process by which the ventricles prepare to contract and pump blood throughout the body. The QRS complex itself represents this depolarization on an ECG, and this includes the sequential activation of the right and left ventricles. The normal duration of the QRS complex is between 0.06 and 0.12 seconds. This is 1.5 to 3 small boxes on the ECG graph paper. A duration within this range indicates that ventricles are depolarizing efficiently and effectively. So all of the conduction pathways, including the bundle branches and the Purkinje fibers, are functioning properly. A QRS duration longer than 0.12 seconds is considered prolonged, and a prolonged duration can indicate that there is a delay in the depolarization of the ventricles, often due to a block in one of the bundle branches. So right bundle branch block, the right ventricle depolarization is delayed, and this delay results in a prolonged QRS duration, often with a distinctive pattern on the ECG, such as an M-shaped or rabbit ears appearance in the V1 and V2 leads. In a left bundle branch block, the left ventricle depolarization is delayed, and this also results in a prolonged QRS duration, typically characterized by a broad, notched, or slurred R wave in the lateral leads. Prolonged QRS duration can be associated with underlying heart disease, such as coronary artery disease, hypertensive heart disease, or cardiomyopathies. These conditions can affect the conduction system of the heart, leading to delayed ventricular depolarization. Patients with heart failure often exhibit a prolonged QRS duration, and this is because the structural and functional changes in the heart muscle can impact the conduction pathways. Patients with bundle branch blocks and significant conduction delays, pacemaker might be indicated to help coordinate the contractions of the ventricles. Biventricular pacemakers, or cardiac resynchronization therapy are particularly useful in synchronizing the contraction of the left and right ventricles. Regular monitoring of the QRS duration is important in patients with known conduction system diseases or those who have any risk of heart disease. Any changes in the QRS duration should be investigated promptly to determine the underlying cause and appropriate treatment. The QT interval is the time measured from the start of the QRS complex to the end of the T wave. This interval encompasses both ventricular depolarization and repolarization. Remember, depolarization is when the ventricles prepare to contract and pump blood, while repolarization is when they reset to prepare for the next cycle. The QT interval is significant because it represents the entire duration of ventricular electrical activity, from the initial depolarization to the completion of repolarization. A normal QT interval is typically less than 0.44 seconds in men and less than 0.46 seconds in women. This duration can vary with heart rate, so it's often corrected for heart rate using formulas like the Bazet's formula, which results in a QTC, also called a corrected QT. A prolonged QT interval is one that extends beyond the normal range, and this can be due to various factors including genetic conditions, electrolyte imbalances, and some medications. One of the most significant risks of a prolonged QT interval is the development of torsade de pointes. Torsade de pointes is a specific type of life-threatening arrhythmia characterized by a rapid, irregular heartbeat that can lead to sudden cardiac arrest if not promptly treated. Beside torsade de pointes, a prolonged QT interval can predispose individuals to other dangerous arrhythmias. These can disrupt the normal rhythm and function of the heart, leading to symptoms such as palpitations, dizziness, syncope, and in severe cases, even death. Certain genetic conditions, like long QT syndrome, can cause a prolonged QT interval. This is an inherited condition that affects the ion channels in the heart cells, leading to prolonged repolarization. Various medications can prolong the QT interval. These include certain antiarrhythmics, antibiotics, antidepressants, and antipsychotics. It's crucial to monitor patients on these medications regularly with ECGs to ensure that the QT interval remains within a safe range. Imbalances in electrolytes, such as low levels of potassium, magnesium, and calcium, can prolong the QT interval. These electrolytes are vital for normal cardiac electrical activity, and imbalances must be corrected promptly to prevent arrhythmias. Conditions like myocardial infarction, heart failure, and cardiomyopathy can affect the electrical properties of the heart, leading to a prolonged QT interval. So monitoring and managing these conditions is essential to maintain a normal QT interval. Regular ECG monitoring is essential for patients at risk of prolonged QT interval, particularly those on medications known to affect the QT interval or with known heart conditions. It should be measured in multiple leads, and the longest QT interval should be recorded. Monitoring patients for symptoms of arrhythmias such as palpitations, dizziness, or syncope is crucial. Any new or worsening symptoms should prompt an immediate ECG evaluation to check the QT interval. For patients who have a prolonged QT interval, management may include discontinuing or adjusting medications, correcting electrolyte imbalances, and treating underlying heart conditions. In some cases, patients may require an implantable cardioverter defibrillator, or ICD, to prevent sudden cardiac death from arrhythmia. The ST segment is the flat section of the ECG between the end of the S wave and the start of the T wave. The S wave is the final part of the QRS complex, representing the end of ventricular depolarization. The T wave represents ventricular repolarization. So the ST segment represents a brief period when the ventricles are depolarized but have not yet started to repolarize. This is a crucial phase in the cardiac cycle because it indicates the period between the end of contraction and the beginning of recovery. A normal ST segment is typically flat and on the baseline or isoelectric line. This flatness indicates that there is no electrical activity occurring at this moment, which is expected after the ventricles have contracted and before they start to repolarize. ST elevation is seen as a rise above the baseline and can indicate myocardial infarction or heart attack. This is often due to a complete blockage of a coronary artery, leading to injury of the heart muscle. ST elevation is a medical emergency and requires immediate attention and intervention. ST depression is seen as a dip below the baseline and can indicate myocardial ischemia. Occurs when there is reduced blood flow to the heart muscle, typically due to narrowed coronary arteries. It can also be a sign of other conditions like left ventricular hypertrophy or electrolyte imbalances. The most common cause of ST elevation is a myocardial infarction. During an acute myocardial infarction, the affected area of the heart muscle becomes injured due to a lack of oxygen, causing the ST segment to rise. Inflammation of the pericardium, the sac surrounding the heart, also called pericarditis, can also cause ST segment elevation. This is typically diffuse, meaning it appears in multiple leads on the ECG. In some individuals, especially young adults and athletes, there is a normal variant known as early repolarization that can cause mild ST elevation. This is usually benign and not associated with any adverse outcomes. Thickening of the heart muscle can also lead to ST depression. This is known as left ventricular hypertrophy. This is due to increased workload on the heart, often from conditions like hypertension. Certain medications, such as digoxin, can cause characteristic downsloping of the ST segment. This is known as the digoxin effect and is typically benign but should be recognized as drug-related. Imbalances in electrolytes, particularly potassium and calcium, can lead to ST segment changes. Both hyperkalemia and hypokalemia can affect the ST segment, causing depression or elevation depending on severity and context. Regular ECG monitoring is essential for patients at risk of myocardial ischemia or infarction, and any deviation from the normal flat ST segment should prompt further investigation. ST segment changes should be correlated with clinical symptoms like chest pain, shortness of breath, and dizziness, because this helps to determine the underlying cause and the urgency of the intervention needed. In the suspected myocardial infarction, serial ECGs, as doing multiple ECGs over time, can track changes in the ST segment over time. This helps to confirm the diagnosis and assess the progression of the condition. Immediate medical intervention is required for ST elevation. We're going to start with oxygen, nitroglycerin, and aspirin. Thrombolytic therapy or percutaneous coronary intervention, PCI, may be needed to restore blood flow to the affected area. Management of ST depression involves addressing the underlying cause, such as improving coronary blood flow in cases of ischemia. This may include medical beta blockers, calcium channel blockers, or procedures like angioplasty. Continuous monitoring and follow-up are crucial for patients who have any form of ST segment changes. Adjustments to treatment plans are made based on the patient's response and any changes in the ECG. Now let's look at the U wave. This is a much lesser known but still significant part of the ECG that provides additional insights into cardiac function, particularly in the context of electrolyte imbalances. The U wave is a small, positive deflection that follows the T wave on the ECG. Not all individuals will have a visible U wave on their ECG. Its presence can vary based on several physiological factors. Remember, the T wave represents ventricular repolarization, and the U wave represents the final phase of that repolarization. It's typically smaller than the T wave, and it can sometimes be very subtle, making it less prominent in routine ECG interpretation. The U wave is believed to represent the repolarization of the Purkinje fibers, which are part of the heart's conduction system responsible for distributing the electrical impulse throughout the ventricles. Purkinje fibers are the last part of the conduction system to repolarize, which is wave appears after the T wave. In a normal ECG, the U wave is usually small and positive, particularly in leads V2 to V4. It is most easily observed when the heart rate is slow, as it tends to just merge with the T wave at higher heart rates. A prominent U wave is most commonly associated with hypokalemia or low potassium levels. It causes an increased duration of repolarization, leading to more visible U waves. Other causes can include hypercalcemia, hypomagnesemia, and the use of certain medications like digitalis. Inverted U waves can indicate underlying cardiac pathology, such as ischemia or left ventricular hypertrophy. Can also be seen in conditions causing increased intracranial pressure. Hypokalemia is the most recognized cause of a prominent U wave, resulting from reduced potassium levels in the blood, which delay the ventricular repolarization. But don't forget that certain medications, such as digitalis, can cause changes in the U wave, making it more prominent. Slower heart rates make U waves more visible as the distance between the T wave and the next P wave increases, which allows the U wave to be more distinctly seen on the ECG. Regular ECG monitoring is essential for patients at risk of electrolyte imbalances or those on medications that affect cardiac repolarization. Look for small positive deflections following the T wave, especially in leads V2 to V4. U wave changes should be correlated with clinical symptoms like muscle cramps and arrhythmias, which are common in electrolyte imbalances. This will help to determine the underlying cause and the urgency of intervention. Correcting the underlying cause of U wave changes is crucial. So, for hypokalemia, potassium supplements or dietary adjustments are necessary to restore normal levels. And monitoring and managing other electrolyte imbalances like calcium and magnesium are also important. Adjust any medications that might be contributing to U wave changes. We might need to alter doses of digitalis or consider alternative medications if necessary. And continuous ECG monitoring is essential for patients who have noticeable U wave changes, especially those at risk of developing severe arrhythmias. Follow-up ECGs can help to track the effectiveness of treatment and ensure the stability of the patient's cardiac conduction. So let's look at the ECG waveforms all together one more time and review what's going on. The P wave represents atrial depolarization, indicating the atria are contracting. This will help us to assess atrial size and function. The QRS complex represents ventricular depolarization, showing the ventricles are contracting, and is crucial for understanding how well the ventricles are pumping blood. The T wave represents ventricular repolarization, indicating the recovery phase of the ventricles, and provides insights into the health of the ventricular muscle and electrolyte balance. The PR interval reflects the time taken for the electrical impulse to travel from the atria to the ventricles. Prolongation can indicate first-degree heart block. The QRS duration is another way of saying we're measuring the time for ventricular depolarization, and prolonged duration can suggest bundle branch blocks or ventricular hypertrophy. The QT interval represents the total time for ventricular depolarization and repolarization, so prolongation can predispose to life-threatening arrhythmias like torsade de pointes. The ST segment indicates the period when the ventricles are depolarized. Elevation or depression can signal myocardial ischemia or infarction. And the U wave represents repolarization of the Purkinje fibers, but it's generally not prominent on the ECG. Prominent U waves are often seen in hypokalemia. We need to make sure that we're accurately interpreting these ECG waveforms so that we can determine the heart's rhythm. Normal sinus rhythm is a consistent regular pattern with a QRS complex and a T wave following. Deviations from this normal pattern can indicate arrhythmias such as atrial fibrillation, ventricular tachycardia, or bradycardia. The ECG waveforms are instrumental in diagnosing various cardiac conditions. Changes in the ST segment and T wave can indicate an acute MI. Pathological Q waves can suggest a previous MI. Abnormalities in the T wave and U wave can point to issues like hyperkalemia or hypokalemia. Prolonged PR interval or widened QRS complex can indicate atrioventricular or bundle branch blocks. And ECG waveforms can also help to diagnose some specific conditions. Irregular rhythms without distinct P waves indicating chaotic atrial activity is called atrial fibrillation. If we have really wide, bizarre-looking QRS complexes without preceding P waves, we have rapid ventricular depolarization leading to what's called ventricular tachycardia. Prominent U waves and flattened T waves indicate low potassium levels, and ST segment depression or T wave inversion suggests reduced blood flow to the. Understanding the clinical implications of the ECG waveforms is essential for effective patient care. Accurate measurement of waveforms and intervals is crucial for proper interpretation of the ECG. Each small box on the ECG graph represents 0.04 seconds or 0.1 millivolts of electrical activity. Each large box represents 0.2 seconds or 0.5 millivolts. Precise measurement ensures that we're correctly identifying normal and abnormal values. Compare current ECG readings with previous ones. This will help us to detect changes over time and helps us to identify new or worsening conditions. Regular intervals and waveforms indicate normal cardiac function. Deviations from normal values can signal underlying issues. Remember, a prolonged PR interval greater than 0.2 seconds might indicate first-degree heart block, while a QRS duration longer than 0.12 seconds might suggest bundle branch block or ventricular hypertrophy. Identifying and diagnosing arrhythmias, ischemia, and other cardiac conditions relies heavily on interpreting the ECG waveforms correctly. We're going to be looking at several of these arrhythmias going on. We're going to be looking at the ones most commonly covered on the NCLEX. And these are things like atrial fibrillation, which are its regularly irregular rhythm with absent P waves, or ventricular tachycardia, wide bizarre QRS complexes without preceding P waves. We may have ischemia or infarction. Ischemia is reduced blood flow to the heart muscle and may have ST segment depression or T wave inversion, whereas an infarction is the death of actual tissue in the heart, and that's ST elevation in certain leads. Hyperkalemia is your peak T waves with wide QRS complexes, and hypokalemia has flattened T waves with prominent U waves. We're going to guide our treatment decisions based on ECG findings so that we have timely intervention. Arrhythmias require immediate intervention. We might need to defibrillate for ventricular fibrillation or cardiovert for atrial fibrillation. We might need to administer medications like nitrates, beta blockers, or thrombolytics. We might have to consider something like percutaneous coronary intervention or PCI if we have ischemia or infarction. Regular monitoring of ECGs in patients with known cardiac conditions to track progress and detect any changes early is very necessary. We may need to adjust medications based on ECG findings. We obviously need to do things like monitor QT interval for patients on drugs that can prolong it. Patients with pacemakers or ICDs need regular ECG monitoring to ensure that the devices are functioning correctly. And post-surgical cardiac patients also require consistent ECG monitoring to detect potential complications. Now let's take a quick look at the placement of ECG leads. This is crucial for accurately capturing the heart's electrical activity. Proper placement ensures reliable and accurate readings, and this is essential for diagnosing and managing cardiac conditions. So we've got 4 limb electrodes. The right arm is going to be placed on the wrist or upper arm, and this measures electrical activity from the right side of the heart and serves as a reference point for other limb leads. Then we have one that goes on the left arm, typically again on the wrist or upper arm. This measures electrical activity from the left side of the heart and serves as a reference point for the other limb leads. Your right leg, again, is going to be placed on the ankle or lower leg. This one is a ground electrode. It provides a reference point that allows it to minimize electrical interference and noise. The left leg, typically on the ankle or lower leg, measures electrical activity from the lower part of the heart and again serves as a reference point for other limb leads. Then we have our chest electrodes. The V1 is placed on the 4th intercostal space, right sternal border, and it measures electrical activity of the interventricular septum. V2 is placed on the 4th intercostal space, left sternal border. This measures electrical activity of the interventricular septum. V3 is midway between V2 and V4, and it captures transitional electrical activity between the right and left ventricles. V4 is at the 5th intercostal space, mid-clavicular line, and this measures electrical activity from the anterior part of the heart, specifically the left ventricle. V5 is level with V4, but it's at the anterior axillary line. This measures electrical activity from the lateral wall of the left ventricle. And V6 is level with V4, but at the mid-axillary line. And this measures electrical activity from the lateral wall of the left ventricle. Each of these leads measures or assists with capturing electrical activity from different parts of the heart. By correctly placing these electrodes, we can ensure that we get a comprehensive view of the heart's electrical activity from multiple angles. This allows us to identify abnormalities and make accurate diagnoses. It's important to remember that incorrect lead placement can lead to inaccurate readings and misdiagnosis. So always double check electrode positions before recording an ECG to ensure the best possible data quality. Proper skin preparation, such as cleaning and, if necessary, shaving the electrode sites, can also help to improve the quality of the ECG signal. So let's wrap up this lecture. We've discussed the P wave, the QRS complex, the T wave, the PR interval, and some of the other waveforms. We've discussed their length and their significance. And we've talked about the importance of accurate measurement and interpretation. We need to remember that correct interpretation helps to identify normal and abnormal values, allowing for the diagnosis of cardiac conditions. And comparing current ECG readings with previous ones can help to detect changes over time, indicating new or worsening conditions. Remember that there's lots of cardiac conditions we can diagnose or treat based on ECG. There's going to be arrhythmias, ischemia, and infarction, electrolyte imbalances, and we need to make sure that our ECG findings are guiding our treatment decisions, including medication adjustments and interventions like cardioversion or defibrillation. Regular ECG monitoring is essential for patients who have known cardiac conditions so that we can track progress, and detect any changes early. Thank you for paying attention during this presentation. If you have any questions, you can ask me in class or send me a message. And remember, don't spend all your time studying. Go do some nursey things.